Hello everybody, and welcome to Georgia Institute of EMS's presentation of our COVID-19 update with Dr. Christy Blanchford. We're honored to have her here today. Thank you so much, Dr. Blanchford, for coming in today to help our EMT students, our advanced EMT students and the paramedics out there and EMTs and everyone from EMS out there to hopefully get a little bit more insight on COVID-19 and even the general public. This is a good program or a good talk for the general public to listen to. With that being said, hey, thank you so much, and let's go ahead and let's dive into this with Dr. Blanchford. Thank you so much.
Okay, hello, I'm Dr. Blanchford. I'm going to be giving a presentation on the current pandemic, the COVID-19. I'm here to dispel some myths as well as to reinforce some real issues regarding this pandemic. A brief introduction. I'm an internist, and I've been an internist for 25 years. I used to be a volunteer AEMT from 1988 to 1999, and before that I was an analytical chemist. So let's just go ahead and proceed. All right, COVID-19, the formal category now is SARS-CoV-2, but I'm just going to stick to COVID-19. The other's a mouthful. All right. So we already are aware of two other coronaviruses in the past. SARS, the epidemic was in 2003, and President Bush was able to nip that in the bud due to some vigorous infusion of resources to the CDC after 9/11. That had a 10% mortality. It was quite scary. MERS, a Middle Eastern respiratory syndrome, was also a coronavirus. It started in 2012 in Saudi Arabia, and that had a 35% mortality, and we were able to nip that in the bud as well. Okay, so this is the thing I have to really clarify about this disease. Is this airborne or respiratory droplets? It's airborne. It's respiratory droplets, not airborne. The reason why people have some confusion regarding this is in the beginning we were looking for N95 masks, and in the beginning of any epidemic or pandemic, the default for a new pathogen is always assume it's airborne. So respiratory droplets are much bigger, much heavier, and they don't travel as far. So 3 feet is the usual transmission radius for a droplet infection. As you can see, if you're about 8 feet away, person C, you won't be exposed to the respiratory droplets and you're safe from transmission. Except for pertussis or whooping cough. The radius of infection for those respiratory droplets are more like 6 feet because of the severe force of coughing. And unlike COVID-19, whooping cough or pertussis is not a zoonotic pathogen, which means it didn't start from animals. It only occurs in humans. So just to review, airborne versus droplet admission. Airborne droplets are much smaller. They stay suspended in air, whereas respiratory droplets are much larger. They do not remain suspended in air. And once again, why the N95 masks? Because the default in the beginning of this whole epidemic was that it could potentially be airborne, but it's not. Okay, so there's a lot of memes and even news outlets saying that this organism has become airborne. Well, just to give you a little window into how we doctors approach these media news about diseases, okay? They're citing, one of the biggest studies they're citing is this Princeton study by Dora Malin. And this article was not peer-reviewed, which is actually very important. And there was a big flaw in this study citing that COVID-19 was airborne. Well, what they did in a lab, so this is not based on real studies in humans, they put the virus inside a pneumatic nebulizer and aerosolized the particles. Our lungs cannot generate such force, unless, of course, you're the big bad wolf. But jet nebulizers are based on the Venturi principle, and without going into the physics, it's how these particles become aerosolized coming from a region of large diameter through a region of small diameter and then back out. Guess what? Our lung anatomy is just the opposite. We go from very small diameter all the way to a large diameter. So it's impossible. This is not indicative of the virus being airborne. And then there was this one quote-unquote study about a bus where some person in the back of the bus infected people more than 4.5 meters away. Well, guess what? This was an air-conditioned bus. The windows were closed. The only way patient 0 could transmit this through airborne droplets was if he didn't move for 4 to 6 hours. So there was no spread through fomite, which is, I'll talk about that, or fecal oral, using the bathroom on the bus. And this was actually soundly rejected by the Journal of Practical Preventative Medicine, probably because of poor quality of study. All right, so to review, respiratory droplets are sprayed in the air, then they fall short at 3 to 6 feet. Exposure does not happen past that distance, with the exception of pertussis or whooping cough. Other diseases that are spread through respiratory droplets, we've all heard of Ebola, the flu, and mumps. Very few airborne diseases currently, but measles and TB and chickenpox are airborne. And when we used to have smallpox, that was also airborne. But as paramedics and AEMTs, you will be in that vicinity when you move a patient with a potential respiratory droplet transmitted disease inside an ambulance. So you have to be careful. You're going to have to wear some respiratory precautions. By the way, this virus has been shown that it can be passed through fecal-oral transmission. Remember other diseases that are passed that way? E. coli, Giardia, hepatitis A, pinworms, polio, and salmonella. Okay, it's not the main route of transmission for this virus, but there's been a few case studies. And as you can see, there's something called the toilet plume. When you flush the toilet, it can generate some droplets within the vicinity of the person. So that is why it's very important to wash your hands after you've flushed the toilet. Public toilets do not have covers, so you cannot flush with the cover or seat down.
So are we pretty safe in with the, like in the bathroom stalls? Does that provide some protection for us?
Well, that's the issue. These studies, you see those scientists looking at a flushing toilet. When you flush that toilet, the stall walls to the side of each side protects of course, transmission to someone in the next stall. But if you're standing there, they've shown that that toilet plume will deposit either bacteria or virus along your pants, the front or the back of your pants.
So then there's the question about the people cleaning that, needing to make sure they wear proper PPE.
Yeah, right.
And if you go in there and you just, it may not be from you, but it could get on the handle. You touch the handle.
Right.
Then you need to wash your hands.
Yes, exactly. So always wash your hands and don't touch your pants if you're within the vicinity of the flushing. Okay.
Just don't flush it.
And then this is probably one of the main transmission of something like COVID-19, fomite or indirect contact. Fomite means an inanimate object that becomes contaminated by someone sneezing on it or touching it, and then it transmits it to another human via touch. We now know with recent studies that coronavirus 19 may last 24 hours to 3 days depending on the surface. Hepatitis B, just to put it in perspective, can last on a surface for 7 days. HIV, very, very fragile outside the body, maybe a few minutes. If there was a large amount of blood, maybe a few hours. But Unlike coronaviruses and hepatitis B, HIV is not a big fomite or indirect contact transmitter. These studies just came out, in fact, 2 days ago. The SARS-CoV-2 or COVID-19 is much more stable in plastic. So, when you listen to the lungs of someone who may have COVID-19, you need to also wipe down your stethoscopes. Okay, that's very important. It's not just gloves and goggles.
And most of the back of the ambulance is plastic. So we need to clean that down really good.
Exactly, yes. Let's see, and apparently it didn't survive too long on copper and cardboard. I think cardboard was 24 hours. So if you're worried about getting COVID-19 from Amazon packages, don't touch the cardboard for 24 hours.
And if you want to give them to me, I'll take them.
Okay. And okay, this is the last way of transmitting COVID-19. Mucous membrane, touching your eyes. Other diseases that can be passed this way, of course, herpes simplex 1 and 2, cold sores, pink eye, everyone knows that. Yeah. Syphilis. Yeah, I know.
So don't pick your nose.
Yeah. And then, in fact, one of the primary Chinese scientists that was studying this, he wore a mask and gloves, but he did not wear protective eye gear, and we think that's how he contracted the COVID-19.
What about the people out there that are saying that we shouldn't wear a mask as a preventative? I'm not talking about when we're on duty.
Yeah.
Like when we're out at the store and stuff like that, because you may touch your face more and stuff. Is that true?
Oh, it's a combination. It's an artificial, crutch. You'll end up touching your eyes, for instance. You may not touch your nose and mouth, but you may rub your eyes. But the studies also show that most people don't wear it properly. There's all these entrance ways around the surgical masks that you wear, and it doesn't seem to prevent someone who's not infected from getting the virus, but it does help someone who's already infected from transmitting the virus by literally blocking the respiratory droplets from coming out.
Oh, okay.
Yeah. So we now know, and you've heard, that the infectivity is higher than influenza. There's a number that we look at, R0, it's a reproduction number, and it applies to people new to the infection who haven't been vaccinated. So, airborne illnesses, by the way, seem to have a higher R0 value than those spread through contact, with the exception of TB, probably because TB takes a long time to express itself. So this is really simple epidemiology. If the R0 value is less than 1, the disease will decline and eventually die out. We're not there yet. If the R0 value is 1, the disease may stay alive, but it's stable and there won't be an outbreak or an epidemic. If the R0 value is greater than 1, then there will be an outbreak or an epidemic. And guess what? The COVID-19, right there at the top, you see that its R0 value is 2 to 3.11. That means one person has it, he will transmit it to at least 2 to 3 people. Measles, remember I said, was airborne. Their R0 value is 11 or 18. One person has it, they'll transmit it to 11 to 18 people because it's airborne.
Wow.
It's airborne. Ebola, a little less than COVID-19, 2. So one person may pass it on to 2 people. And Ebola has the same mode of transmission: respiratory droplets, mucous membranes, fomite transmission. And seasonal flu right now, R0 is only 1.3. So yes, this virus is much more contagious. You're more likely to get it than the seasonal flu. Okay.
Now, is like the flu vaccine, is it shown to help us any at all?
Yes. The flu vaccine, even though it may not have a 90 or 100% protective factor, it does reduce mortality in those, clearly reduces mortality in those 65 and older and 5 and younger. Between those ages, most of it is morbidity. it reduces the rate of infection, spread of infection. These people take the flu shots, someone such as myself, not because I'm more likely to die from the flu, but I don't want to spread it around.
But does it help at all with the COVID, though?
Nope, not at all.
But would you recommend people getting it still right now?
Yes, getting a flu shot so that you don't get the flu, which is right now taxing our healthcare system
So
greatly.
as many people we can keep out of the system, the better.
Yes, keep them out of the hospitals to make room for this virus, and I'll be touching on that towards the end of the talk.
Cool.
Mm-hmm. Yeah, good point. And once again, just to bring back smallpox, remember that was also an airborne pathogen. Unlike COVID-19, its R0 value was close to 6. And if you survived it, you were scarred greatly. That's why I have a picture of Queen Elizabeth I. That's why she always wore that pasty white makeup, because she was incredibly disfigured from smallpox. By the way, this R0 value is not a good number for something like malaria, because it's not transmitted from person to person. So there's a human infectivity to the mosquito. Mosquitoes can drink your blood, get the pathogen, and then transmit it to someone else, but that's a whole different way of calculating things. So now I'm going to talk about mortality versus case fatality rate, because you're hearing all this stuff, how lethal is this virus? Now, just to put it in perspective, in 1918, everyone knows about the influenza pandemic then that killed over 50 million people worldwide. It had a 2.5% mortality. So just to put that in perspective. Okay?
And that's the Spanish flu?
Right. Well, it wasn't really the Spanish flu, but
well, that's what they call it,
yeah, they call it, right. But yeah. And now the current influenza epidemic is 0.06 to 0.107%. Doesn't seem like a lot, but you don't want to be that 0.06%. In fact, I just had a 21-year-old die from this. So the flu hits closer to home for me right now than the COVID-19.
Right. My mother died from the flu. She had dementia real bad. She got the flu. It progressed to pneumonia.
Oh, yeah.
And that's...
Yeah. It's like I said, and then there was this policeman, I think, in Conyers,
right,
Rockdale, that 41 died of
just
the
a few
flu.
months ago.
Right, not too long ago. So that's a palpable, problem for me currently. Now, so right now you're hearing numbers that COVID-19 has a 3% mortality in the U.S., but it has as low as a 0.65% mortality in South Korea. So here's a quick statistics lesson. The above is due to selection bias, okay? Due to the shortage of testing kits, we're only testing the very sick, the ones that are almost at death's door. And this is unfortunate because, we've had maybe 5,000 tests in the last 3 months, where South Korea tests 15,000 people a day. And so they're able to get the mildly sick COVID patients incorporated into their case fatality ratio. And that's what a case fatality rate is. When people say mortality, they're really talking about case fatality rates, which is deaths of the people who are sick, versus mortality, which is deaths per population. So mortality can include everything, heart disease and flu deaths in the winter months. See what I'm saying? Mm-hmm. Whereas case fatality rate is specific to that disease, like COVID-19, versus heart attacks.
Right.
Okay. All right. Now, remember, SARS had a case fatality rate of 10% and MERS 35%. But COVID-19 has now gone from being 10 to 20 times as deadly as the flu to now 3 times as deadly. And hopefully it'll keep dropping. But it's still a force to contend with. Now, here's the other issue muddying the waters. When I send my patients to get tested for COVID-19, many of them are testing positive for the flu and something called the human metapneumonia virus. Now, It circulates as the same time as the flu, and it's second behind RSV. You've heard of RSV as an upper respiratory tract infection in children. And it can have the same symptoms as the flu and COVID-19. Now, why am I talking about this? Because many of my patients who have lung disease like COPD, many adults are affected by this as well. And this is what's going around and putting people in the hospital alongside the flu. Okay? In fact, all my transplant patients who are immunosuppressed, if they get this human metapneumonia virus, we're talking 50 to 80% mortality.
Oh, wow.
So you see why the COVID-19 virus is scaring us.
5 minutes.
Okay. All right. We have this putting patients in the hospital. And let's quickly go through the COVID-19 demographics. We're finding that the lethality is very high in people 80 years and over, 60 years and over. Children are almost not affected by this at all.
Is it true that some of the children have it, but they're not showing any symptoms?
Any symptoms. And I hypothesize, and no one's proved it yet, that the COVID virus acts on ACE2 receptors in the lungs, and children have far less developed ACE2 receptors in the lungs. Because remember, it's opposite in the flu. Young children, 5 and younger, are clearly killed, flu is very lethal.
Yeah, we're very worried about
Yes.
the young and the elderly.
And the elderly. Whereas with this COVID-19, that demographic, we don't have to worry at all.
But they're carrying it, though,
Yes,
right?
and passing it along. Exactly. They're germ pits.
So all these teenagers that are at spring break could be getting it and just
have no symptoms.
They may have minor cold-like symptoms.
And they're bringing it back to their communities.
To their elderly parents.
Yes, elderly parents or immunocompromised
or grandparents.
parents. You know, they're on medicines for their rheumatoid arthritis or psoriatic arthritis. Okay. Anyway, that was just... and once again, this is China. 80% of the cases are 60 and older. Men in China seem to be dying at a 3-to-2 ratio versus women. But we think this is confounded by the fact that many Chinese men smoke more than women. Many of them are diabetics, and of course, lung disease are very prone to this virus in terms of mortality. Okay, so are we overreacting? After all, from what everyone's been hearing, 80% of the people who get exposed to this will have a very mild disease. 20% will get sick, maybe 10% will get real sick, and another 2 to 5% will end up on a ventilator. So yes and no. People who know me know that I have a twin sister who was a history major, so I always like to put in a little historical perspective. Back during the 1918 flu, there were epidemiologists around even then, and you can see a big difference in terms of two cities and how they responded to a pandemic. One city downplayed the Spanish flu or the 1918 flu, and another one definitely responded to calls for banning public gatherings. And look at the difference in the mortality between the two cities. So you heard about this this need to flatten the curve. Well, this experiment was tried and done back in 1918. Okay, so here's the problem. Let's look at hospital beds per 1,000 population. We have about 2.4, 2.6 hospital beds per 1,000. South Korea has close to 9 or 10. Italy, where you're hearing a lot of horrible stuff, has about 4 hospital beds per 1,000, and they're overrun. If you haven't heard the news, they have almost no beds left. Okay? So Italy has 4.4 beds per 1,000. We have about 2.8 beds per 1,000. Any persons over 80 in Italy, as of a few days ago, they are postulating will have to be left to die. They'll be turned away from the hospitals because they are just running out of bed. and this is what I want to explain to you. 2 weeks ago, okay, from March 16th, they had the same number of patients infected per capita as we have March 16th, okay? We think linearly, not logarithmically or exponentially, and that's our problem. Now, Wuhan, remember the start of the epidemic, went on lockdown after only 400 cases were identified. Of course, they're able to do that because they're a totalitarian government, and they had access to testing that, unfortunately, we have failed to do as well as of today. And look at that. Even though they enforced severe quarantine and lockdown, they went from 400 cases, exploded to 80,000 cases very quickly. And so there's another thing that the epidemiologists are worried about. Because the symptoms are so mild, they're saying that for every known case that we know definitively as COVID-19, there's probably 50 as in 50, unknown cases. Okay, these are the children walking around barely sick, the teenagers who think they just have a mild cold. Okay? So the CDC says the virus is everywhere. It's already everywhere. March 15th, there were 3,115 cases reported of COVID-19 in this country, and assume 155,000 cases are not reported. That's how you have to look at it. March 18th, there are now 6,423 cases, so that was just a day or two ago. So there's an exponential. You already see that this has doubled in 3 days. Okay, so let's do the math. Now you're going to see why your math teachers have taught you something called logarithmic growth. Okay.
Oh no.
No. So, but this is actually going to make math sound scary. All right. So assume there's 20,000 actual cases. Okay. And it doubles every 3 days. And there's 10 3-day periods in a month, 2 to the 10th power. It's 1,024 times the number. That means in 30 days, we're going to go from that 6,000 plus to 20 million Americans infected. 10% will need hospital beds. That means 2 million beds needed. American Hospital Association says we have only 924,107 beds based on a 2018 census. And 65% of these beds are occupied by flu, heart attacks, strokes, human metapneumonia virus. Do you see where I'm going?
Yeah, just because COVID-19 happens doesn't mean car wrecks aren't happening.
Exactly.
Shootings aren't happening.
Heart attacks, meningitis, the usual stuff. Now, and according to the percentages we see over in China, of that 2 million that needs hospital beds, 100,000 will need ventilators. And guess what? By our estimates, we have maybe 100 to 150,000, depending on who you ask, ventilators in this country, and 40% are already being used for our current patients.
Wow.
Right. So you see, if you think logarithmically rather than linearly, you see why countries and governors and leaders of state are almost in near panic. Okay? And you can ask any nurse or ER, our hospitals are using 5 months worth of supplies in 6 days because of the personal protective equipment, right? We have to have masks when you go into these rooms.
Yeah, you can't even find the mask at Home Depot anymore.
That's right. That's right. And for instance, according to a CNN report, our local hospital here, Putney Memorial Hospital in Albany, Georgia, has 5 more days worth of supplies, despite being prepared with 6 months worth of equipment. And this is as of March 18th.
That's Phoebe Putney.
Mm-hmm.
Wow.
In Albany.
That's a huge hospital,
That's a huge hospital, right. And they are going to run out, in, I guess, three more days.
Wow.
Switzerland, by the way, which has 6 beds per 1,000, March 18th, Reuters News. Swiss hospitals face collapse in 10 days if virus keeps spreading. They have more resources and more beds than we do, and they're already facing, apocalyptic conditions. Okay. So, once again, this is a mild disease for 80 to 85% of the people who get it. 15 to 20% of the cases will be serious and require oxygen and hospitalization. 5% of these cases will become critical, requiring machines like ventilators. So if you look at the numbers, it is scary. Now, the only way to stop this virus without quarantine and other drastic measures is to have 50% of the population develop immunity, which hasn't happened yet. But ladies and gentlemen, now you're beginning to understand why pro-vaccine efforts always stress herd immunity.
Yes.
Okay? All right, so what's in the horizon? Okay, I don't want to be all gloom and doom. There's got to be some hope here. Well, we can look to a drug that was initially studied for Ebola, and it, by the way, failed profoundly, called remdesivir. And it showed extreme promise for treating MERS and SARS, which are the other two coronaviruses, in animal models. And we are already doing human randomized control clinical trials of this drug in hospitalized COVID-19 patients who are very sick. You know, they're on oxygen or on the ventilator. They've already started doing it at the University of Nebraska Medical Center in Omaha, led by Dr. Andre Khalil, a professor of internal medicine, funded by the NIH. Okay. And there's a concurrent human trial being studied in Alberta, Canada, all going on this month. The case studies have been dramatic. One of them, and this is in the New England Journal of Medicine, March 5th, this is all very recent, one of the patients received the drug on the 7th day after infection when he was on the ventilator, severe pneumonia, and this was in Washington State. The symptoms abated on the 2nd day of the drug administration, and he was off the oxygen and out of the ICU in 2 days.
Well, that's promising.
Yes, very promising. So that's one of the treatment in the horizon. And going back to history, we're actually talking about doing plasma transfusions from recovered patients, right?
And they started doing that with Ebola too, didn't they?
I think so. Ebola and the Spanish flu, right. It's called convalescent plasma. So, yeah, during the Spanish flu pandemic, they did transfusions of patients who had recovered, and it increased the survivability rate by 50%.
So we need to find these kids.
That's right. Or
And
adults,
they probably lost their jobs, so they probably go sell some plasma.
Plasma, that would be great, yeah. They did that in 1934 when there was a measles outbreak in a boarding school. Remember, this is before vaccines were created. They harvested the serum from the first infected students, and only 3 of the out of 62 students developed the measles when 100% had been exposed. So we know it can work. So fresh frozen plasma from patients who have recovered. I think Italy is doing that right now. Okay. IVIGG is there's a Takeda, Japanese pharmaceutical firm, which is intravenous immunoglobulin. Remember, that's all the antibodies, but it's purified and concentrated pooled from many recovered people. So it's not just one person's plasma, it's say 50 people who have recovered from COVID-19. We combine those antibodies, and because of the low volume of treatment, and they also make sure there's no potential viral infections that can be carried by raw plasma, this will be a safer means of treating these COVID-19 patients. And then you've probably heard in the news the malaria drug, hydroxychloroquine. We use it to treat malaria, but I also put it on my lupus patients or my arthritis patients. It's very good for that. It was just studied in 26 COVID-19 patients. What you didn't hear in the news was it was the combination of the hydroxychloroquine chloroquine with azithromycin combination that really had the best protection from mortality.
Yeah, because the Zithromax, it has some antiviral, right?
Yes, yeah. So it was the combination of the two very cheap,
Right.
reasonable.
But a lot of people are allergic to
Zithromycin, yeah. And the anti-malaria drugs, if you have certain G6P, deficiencies, certain enzyme deficiencies, we can't use that on you. So, of course, the holy grail is the vaccine.
Yay.
Yay. Vaccines
Maybe.
work by teaching the body to make its own antibodies, to an infectious agent without the person being infected in the first place. So, typically making a new vaccine, believe it or not, takes about a decade or longer. But with our new ways of genetic sequencing, replicating DNA and RNA, we're hoping it'll be relatively quick. But relatively quick still means 18 months.
Or so.
Yeah,
I heard on the news today they're starting the field trial one now.
Yes, and I'm sure in countries like China where, human guinea pigs are
easier to find.
Yes. So,
but I don't. I mean, the people in Italy, I would think,
right.
It's bad there.
Yeah, it's so bad. Yeah, it's like I said, they have
they're
no
going to
beds.
get desperate.
Yeah, they may go ahead and do that as well. I do know there's a team in Australia and one in Philadelphia in collaboration with the pharmaceutical company called Inovio. I think that's based in California. I can't remember. And then there's one called Moderna in Massachusetts that apparently is the furthest along in this vaccine, and they're already testing it in humans. But like I said, even then, it'll still be a year to 18 months before these come out for mass use.
Now, let's say if I get it now, I'll build some antibodies for it. But the problem is next season is it going to mutate like the flu does?
Right, like the flu, right. We it's an RNA virus. Basic microbiology, RNA viruses tend to mutate more than DNA viruses like smallpox. That's why you just needed the one vaccine and we eliminated it. Right? It hasn't changed and morphed every year. So, yes, it has a potential to mutate. Will it mutate every year like the flu? I don't.
Time will tell.
Time will tell. Exactly, time will tell. I think MERS and SARS didn't seem to mutate that quickly. Although you can, I guess, reasonably say this COVID-19 is a mutation of, say, the SARS.
Right.
Yeah. And it's interesting because if the virus is smart, we know they're not, but if the virus is smart, they don't kill their host, right? As easily.
But they're saying there's potentially two strands now. One, like in Italy, is the really bad strand, but then there's some with the lower mortality.
Right. We think there are two species right now. Yeah, one with higher mortality, but the second one has higher virulence. So its R naught factor is probably higher. It's more contagious, but it's less lethal. Because
it wants to live.
It wants to live. Exactly. A smart virus will want to live. They don't want to kill off their host like Ebola quickly.
Right.
So. And that's the end of my talk.
Yay. Well, thank you so much, Dr. Blanchford. This has been a great presentation. I think it's going to get the word. But I have just a quick question out there, because and I just want to point out there to everybody that this has nothing to do with any nationalities. It doesn't matter where you come from, who you are. People from Georgia are getting it just like people from Wuhan getting it. And we can't, be out there discriminating or being mean to anybody else. We need to treat all our patients the same, with the same dignity, respect, and everything else and stuff regardless. Because more than likely, I think the numbers out there say that at some point we're all going to get it. Like the flu, almost everybody's had the flu at some time.
Yeah.
And probably through just life, this is probably going to be it'll end up being a normal thing, and we'll adapt to it.
Yeah.
eventually.
You're right, because viruses have no respect for nationality or borders and it's interesting, as there's a lot of animosity between Japan and China for obvious reasons, but Japan donated thousands of masks to China, and they had a really nice poem written in it that said, we may have different politics and different ideologies, but we share the same sky and the moon.
Yeah, that's really good.
So it's brought even those two countries somewhat together. So it just shows you how, these pandemics are truly a global phenomena. It's no longer a local phenomena.
Yep. Mm-hmm. So something to take away: wash your hands, use your PPE, and if you're sick, stay home.
Right.
So, well, thank you very much. And hey, we'll see you on our next podcast. Okay. Thank you. Well, thank you so much, Dr. Blanchford, for that wonderful presentation over COVID-19. Hopefully that's helped clear up a lot of misinformation out there, give our providers out there the tools and the resources and the knowledge that they need to be confident when they're working out there in the field. And thank you so much for your time, Dr. Blanchford. We know you're busy. You're out there on the front lines of this, taking care of patients every day, and we appreciate your time. And everyone across the state of Georgia does. So, hey, what if you're watching this and you still have some questions or whatever? Just shoot us an email at info@gaiems.com, and we'll be glad to answer your questions. We'll hunt down Dr. Blanchford and ask her. This one may take us a little longer to get back any technical or specific questions because Dr. Blanchford is very busy there. But give us, shoot us a line, and we'll be glad to help you there. Or you can call us at 678-561-2368 there. So also, too, hey, if you're interested out there, let's say you're out there and you're just a regular citizen and you're interested in EMS, or you're a college student, you got something to do, hey, give us a shout, Go to our website, georgiaemt.com. We've got EMT and advanced EMT classes starting about every 6 weeks. You can also check us out for all of you professionals out there that are providers. We have continuing education out there for you. You can do them 24 hours a day, 7 days a week for your distributive education and get your certificates out there. All 40 hours for the state of Georgia is on there as well. And you can get us there at myemsconed.com or give us a call at 678-561-2368 or email us there at info@gaiems.com, and we'll be glad to help you out. Once again, hey, my name's Tom Camplain, and thank you for sitting through this presentation, and know that we are out there praying for everybody. We're out there supporting y'all, and y'all stay safe, okay? Thank you.